shown also amputee, that they had reported it as an adverse event instead of as a side effect in their studies.
Oh, okay. Yes. So, what I think, we are going to learn a lot more. So, yes, this is just what these documents are endorsing for some reason. I think they were very early to put this out, and I think they're revising as new data comes out, or they should revise them.
Well, like you showed earlier, the 2 slides prior with the credence trial, and about it's outside of the HbA1c in regards to the lowering the protective property in the kidneys, and going through. And there's even the credence, is, like you showed in there, was stopped early because they showed how much protective properties canagliflozin was showing in those patients in regards to protective properties and renal impairment, not extending the time to have to go to dialysis or due to hospitalization in chronic kidney disease.
Right, correct. So this other type of drug, the glucagon-like peptide receptor agonist, the GLP-1RA, it's an incretin, and that's what we think is their mode of action. They have also demonstrated benefits in cardiovascular risk in patients with type 2 diabetes, but this effect is later. This one appears to be more related to atherothrombosis and not acute hemodynamic effects like heart failure benefits. So the available data suggests potential for clinical. So of the 6 FDA-approved drugs, liraglutide is the one that significantly lowers atherothrombotic events. And at the time of the writing of this document, that's the one that the ACC endorsed as well. So they showed decrease in MI, stroke, and cardiovascular death. And there is one of them that reduces hemoglobin A1C significantly, and they had some concerns for retinopathy. So, what else? The mechanisms of action, I'm just looking at the time. GLP-1 is a peptide hormone released from the distal ileum and colon after nutrient intake, and following the administration, so these are injectable drugs, and given about once a week, supraphysiologic concentrations of GLP-1 reduce glucose by increasing glucose-dependent insulin secretion and decreasing glucagon secretion, and by delaying gastric emptying, which leads to satiety. So this seems to be the mechanism by which you lose weight, and there's also lowering of blood pressure. So as I was mentioning, the outcome improvement is later, about a year after initiating, which implies maybe some effect on atherothrombosis rather than hemodynamic effects, and independent of glucose control. They tend not to precipitate hypoglycemia, and the mechanism seems independent of hypoglycemia. So I think that, let me see what else. Side effects, there can be some anorexia, nausea because of the delayed gastric emptying, and in people with pancreatitis or thyroid tumors, they don't recommend using them. So how do you decide which agent to use? So if you have a patient with high risk for heart failure, let's say a patient who's had a hypertensive cardiomyopathy, has, a stiff heart, has had several heart failure hospitalizations, then, or has established heart failure, then you can say, hey, maybe an SGLT2 inhibitor would be better. If people have prior amputation, severe peripheral artery disease, several MIs, those people who keep coming back despite our best efforts, you would probably be better off with the GLP-1 receptor agonist. So There,
These diabetics that you're talking about, or general population when you say?
diabetics, diabetics. So that's a good question though, because now it's coming up since
Yeah.
we don't have a glucocentric approach anymore. Can we extend this into people with pre-diabetes and possibly people without diabetes? So those are all things that are up and coming, I think.
And the GLP-1s are indicated for obesity as well and weight loss, so they're used in patients that don't have diabetes.
And so, no, I'm just going to finish with this one. So it invites a patient-clinician conversation, of course. So you ask your patient if they would be willing to use these injectables. Some people don't like injectables at all, so they prefer the oral medications, the co-pays, the T-cell, which patient has more risk of one or the other, and then contraindications. For some reason, the SGLT2 inhibitors have a contraindication with GFRs that are pretty high, less than 60 or less than 45 for different drugs. And it's mainly because they think that with those GFRs, the glucose lowering is less effective, but we're not using these drugs in general to reduce glucose levels. We're using them for their cardiovascular effects. So these things might change within the next few years. And I think I'm going to stop here in the interest of time, and maybe
Just a question, is it IM or sub-Q or what kind of
Sub-Q.
injection?
Sub-Q. I am, yeah, it doesn't hurt that much.
I think this is really fascinating, especially as a stroke neurologist. I know, I haven't read all these papers actually, but we are definitely not routinely prescribing these medications, but we would be excited to, like, or to work with somebody who would prescribe them. So you are prescribing them. Is it easy? Are you running into problems with the insurance today? Oh, is that what you're talking about?
So I want to introduce Rose Pavlikos, who has been a pharmacist in our practice, in the Cardiovascular Prevention Center, and she is leading the effort to get our patients what they need. She works with them in obtaining the right insurance. She's done phenomenal work, and she takes our patients to goal and is just invaluable. And I want to thank you for all that you do for our patients.
Thank you. Thank you for having me. I'll try to make this quick. So my name is Rose Pavlikos, and again, my primary role in cardiology is actually medication therapy management. I help with doing the titrations and adjusting of medicines, monitoring labs, and following up and getting patients to goal for their chronic disease states. But I've spent a lot of my time since starting there educating our staff on how to do prior authorizations and get patients access to their medicines. And we've tried over and over again to figure out who's the right person to do this. And I recently, in December, thankfully hired a pharmacy technician who's done some excellent work, and I'm going to share with you some of her tricks. And she's right here. This is Christine. So Christine has showed me that we, in our clinic, complete 116 prior auths per month. And on average, she has had an 87% success rate in getting these meds approved. For those that are not approved, we either have been able to switch them to alternatives, or we do appeals, and all of our appeals end up, at the end of the day, typically getting covered. So our major platforms that we use are CenterX and Cover My Meds. CenterX is great because it works with an Epic, but Medicare Part D patients can't use it. And Cover My Meds is excellent because it's got a variety of different things that are helpful to, resources that are helpful to us. It gives us reminders when we need to do prior auths. It helps so that when we're doing renewals, you just press a renewal button instead of rewriting the entire reason for prior authorization. And so these are the tools that we have found helpful. When we run into coverage issues or patients who have high copays despite the fact that we've gotten these agents covered, these are the typical tools that we use. So we can call the insurance and ask for tier exceptions, which means that it just brings them to a lower tier if we can prove that they actually need it. Copay cards, which can only be used for non-Medicare Part D patients. 340B program, So we're lucky enough to be an institution where we have 340B pricing options through Walgreens. I, like Eveline was talking about, host every year a Medicare Part D open enrollment, free service to all of our patients. So many of our Medicare Part D patients don't understand that they can actually switch their prescription drug plans every year and that formularies change. And so last year we met with what would you say, like 50 patients, I would say, and we helped them on average save between $50 to $500 for the upcoming year. So it's been really successful. And then we also help our patients sign up for patient assistance programs through the manufacturers. So it's a lot of work and takes a lot of training, and we've been very successful having our pharmacy technician there helping to do these things. I'm going to talk a little bit about the drugs that we've been discussing today and what we've done to help get these types of medicines covered for our patients who, as you can see, really need them. So essentially the way that we start this off is we make sure that it's actually indicated. And when I think about doing prior auths, basically the only thing that you're doing is educating the insurance company as to why you're using this agent. And so documentation from the provider is very important. So we make sure that it's indicated. For our PCSK9s and Vascepa specifically, the insurers want labs within the past 30 to 60 days. Approvals are typically good for 6 to 12 months. So if you can imagine, if we didn't have Cover My Meds reminding us that these approvals are necessary, what would typically happen is that our patients just would go months without them because they would go to the pharmacy for a refill and then come to find out that they needed a prior auth renewal. So we're either using Cover My Meds to do that, or Christine has created an excellent program where she forwards herself in basket messages for a delayed time frame, so that in the next 4 to 6 months when we need repeat labs or when we need to do the renewals, she's aware of that. For PCSK9s, as you all may or may not know, when they were first approved, they were $14,000 per year. That cost was decreased in October of 2018 by 60%, now down to $5,850, but still very, very expensive, as you can see. Typical copays now are running between $50 to $200, but previously $500 to $1,000 per month for these patients. For Vascepa, the cash price is $380 per month. With copays, typically they range between $25 to $380 per month. So our SGLT2s, as Dr. Stock had mentioned, this is kind of a new thing for us in cardiology. We haven't been doing many prior auths for them, but I will tell you, based on my experience, for our diabetic patients, they're not very hard to get covered and approved. I think that for our heart failure patients alone, we may have some trouble, but this is what we know so far. So anyone who has diabetes who's been on metformin, essentially with an initial A1C of greater than 7.5, we should be able to get coverage. Now, if we don't and we're having to do appeals, we're going to attach all the trials that we just discussed to our appeal letters and hope that that helps us to get the approval. The cost for these for cash price are also very expensive, $500 per month, and the copays typically range between $19 to $500 per month. So just keep in mind as you are prescribing these that they're not low cost, and so they definitely need to be used for the right patients. So what have been our keys to success? The first thing is educate. The second thing is make sure that when you're documenting that your staff who are doing these prior authorizations have the information that they need to be successful in getting the patients what they need. We typically, like I said, include primary literature in our appeals. That has helped us a lot. And then we use smart phrases so that we're communicating within the clinic, so that if a patient calls or if a pharmacy calls and says, hey, we need to check in on the status of this prior authorization, people aren't running around with their heads cut off saying, I don't know what's happening, who did this, what happened? We've created smart phrases and document in the electronic medical records so that everyone's aware and everyone can see exactly what process has been done and where the status is of that prior authorization. And again, for follow-up for our patients, we typically use the in-basket messages as reminders, and then also have wonderful Cover My Meds that helps remind us. And this is all I have. I just wanted to give you a little quick overview of what we've been doing to help get these medications covered. Yes?
Can you explain to me why the claims are made that Vasipa is superior to fish oil?
Uh-huh.
And because of the chemical composition, I have trouble accepting that. Can you comment on that? I mean, couldn't a physician be just giving fish oil to these patients?
So maybe we could.
We have a great person in the room to comment on that, actually.
Mindful that you shouldn't get fish oil from the Baltic Sea because it has methyl mercury in it.
Well, all I'll say, John, there's not a single fish oil study that has ever shown improvement in outcome.
I'm aware of that. I'm just wondering why chemically.
Well, chemically, I mean, I think it has to do with the fact that if you take, let's say, a dietary supplement and you look at the content, even the highest or the purest of the dietary supplements might have 17%
Okay.
EPA, DHA. The
Wonderful.
rest is just saturated fat. So it's taking that aside. But then if you look at DHA, EPA combinations versus pure EPA, I mean, there is a lot of science that would suggest DHA isn't necessarily beneficial in the vasculature. It can raise oxidized LDL, can actually be pro-inflammatory in certain settings.
But it actually interacts in some pathways where EPA does not too, so
No,
we
I
need to
agree,
explore that.
but there's no positive outcome studies for
Yeah, I'm
the
aware of that.
combination products. So if you're looking at pure EPA, there's basically two formulations, a Japanese formulation and the US formulation, and I think the outcome studies are strong in those areas. And if you look at the most recent guidelines just published last week from NLA, and then you look at the guidelines published 3 weeks ago by ESC, and you look at the AHA advisory commentary 4 weeks ago, they all say categorically that dietary supplements should not be used, that there's nothing that suggests a benefit and they're not FDA approved on any setting. So I think that, 20 million people take dietary supplements. They spend on average $50 to $200 a month.
What about Lovaza?
Well, Lovaza is a combination EPA-DH compound. I mean, the outcome data, the 4 outcome studies were all negative. Why were they negative? Because we don't think there was enough EPA. And we think the benefits of the DHA perhaps weren't necessarily what you would want. So look, I think it's a great area of research, but in terms of official supplement, we're talking about consumers spending so much money on supplements, and they're getting no benefit instead of taking an SGLT2 with a copay of $50. Rather take that than official supplement that is doing nothing. But for certain risk patients, I think adding a prescription strength high dose of icosapentadyl ethyl based on the outcome study could reduce it, I think makes sense.
So
I
that
think that's what
trial was done at Harvard by Deepak Bhatt, who's the head of interventional cardiology at Harvard. The REDUCE-IT trial showing very significant all-cause mortality reduction. So we had this discussion a few months ago, Dr. Sky and I, because there have been so many failed trials on fish oil. Could you just talk about what your conclusion was?
Not to put you on the spot.
I'll even give you the
Well, you drove all the way down here.
So John, would you agree that if we get the concentration higher with fish
I
oil,
was
but how much?
addressing the question.
Yeah.
It looks like, at least largely, a concentration effect. You're getting more EPA. But, I wonder if there are some pathways that the DHA participates in that haven't been adequately explored, may have importance. But I'm fully acknowledging the actual published comparative data. I'm impressed with that.
I'm looking forward to your genetic testing to say who will benefit.
What other questions are there for the speakers or for just discussion? It's It's an open floor for the next 5 minutes.
Also, discussion on the SGLT2 class. I mean, I think with Repatha, that's more challenging in regards to their coverage.
Oh, yeah.
Compared to the SGLT2 class, you know, you're looking over 90 to 94% being in a preferred tier position. I understand with Medicare Part D, that's going to be a challenge, because you'll have people that get in the donut hole, but that's for any of the branded drugs and then coming out. But a lot of times those co-pays, like you said, you know, you're looking at 20 to, you know, 30 on average is pretty reasonable, and it is an oral agent. You know,
Although, do you
so-
see that chinging considering the new indication? Because I've discussed with some insurers, and they're not even necessarily familiar with these new indications.
Are you
And
talking
so-
about the new, like the credence for kidney protective?
And heart failure.
Yeah, canagliflozin. A lot are, and we can even ask one of our in-house with Blue Shield, but a lot have been made aware and are their clinical teams. Well, I know that their clinical team at Blue Shield has been very much aware of the credence trial for canagliflozin, which is in Volcana, and as well as EMPA with their side on cardiovascular with that. I think what you're gonna have to see at first is, I think the health plans would most likely put a prior off on, if it's not already in a preferred position, and showing that, okay, this person does have end-stage renal disease, or if there's other cardiovascular risk, and they'll
And then
improve it, like
they'll-
what you're doing, showing
Yeah.
the study data. I think once they start seeing more and more demand, then they'll revisit it and see like, okay, then we'll put it in a preferred position. With credence, with canagliflozin with Invokana, there was no additional amputee in the credence trial with that. And so I think, I just get frustrated a lot of times with the SGLT2 class. We're ready to say class effect on the positive part, but then we're ready to try and define them when there's a
That's interesting,
negative,
right.
you know.
And the amputations were not like severe amputations.
Oh, yeah.
They were like toes
And
and
this was
midfoot.
like-
Not that you want one, but.
You know, it was like one per, you know, it was like 1 per 100,000 patients' lives.
It
It
was
was
very
so
good.
minimal.
Right.
And
It was
these were
minimal.
patients that were, you know, they had already lost a limb or so forth with that.
Can I just suggest that there's a wonderful parallel here with our discussion earlier about aspirin,
Yeah,
where you've gotta look at the large effect and then look at, you know, yes, there's a downside risk, but on balance, what is the
Right.
truth for specific patients? So it was actually, and I won't name the health plan, but it was actually a health plan medical director that sent me the Reduce It trial on icosapent ethyl and said, look at this all-cause mortality, this is stunning.
No, and
So-
we're seeing
I'll say one thing about the health plans, because I work with them very extensively. I'm amazed how interested they are in evidence-based and outcomes-based medicine. You know, I know it might pretend I'm not with the company and my boss that doesn't hear this. I think the PA process is a good process for the correct patient selection. You have to start off with a new drug therapy until it's been out and you've had a lot of experience. You have to select the patients that are included in the trials. You can't just, you know, say, well, all diabetics, all patients with hypertriglycerides get one other form of therapy. But I've noticed in the last 5 years tremendous improvements in the way health plans are evaluating these medications. And they put a lot of resources into this as well. So I give them a lot of credit. Blue Shield is one of the companies that I think has a terrific division that deals with that, and I think their criteria are appropriate. You know, I just wanted to say that because I know that the plans take a beating with these new drugs where people say, you know, they're doing something and the plan's not allowing it. I think there's a lot of appropriate utilization.
Well,
Any-
previously the criteria just was not appropriate, and then they had lay personnel who were uneducated marking off boxes, and that created a lot of issues for us because they didn't read what we wrote, and so that was an issue. But I will say that that has improved significantly for many of the plans, and that there are still a few that need
because the first response is gonna be no, you know, and then until you keep, and then pushing back, and if I can't push enough to everybody in the room and even all the lay people, that you gotta be an advocate. You know,
Right.
help your doctor, but be for yourself and your family members. Push in, there is the appeal and grievance line, there is, you are paying for that, you know, insurance. Speak up and say something.
But
And-
not every doctor's office has a Christine.
Correct.
And so because of that, I think that the insurance companies should continue to work on doing a better job at having the right people evaluating these. And I think they do, but the initial step sometimes
it's a
goes
check
to
the
the
box.
wrong person.
Maybe Punim can speak on her experience if she
Sure.
wants.
Let's just hear
from there.
Well, with all due respect, I don't think the first response is actually no from the Mr. Blue Shield. It's usually not a no. It's actually documentation, and you would be surprised, because I've been on the other side, and we see the documentation that we do receive, and it's incomplete. And a lot of times it's physician documentation that's incomplete. So we try actually working with the offices to get that information, so that we can approve it.
Yeah.
Because that's what we're actually looking for. We just,
Right,
we do
and
check
the
the
response is
boxes.
no, because it wasn't completely
It
filled out.
wasn't completely filled out. It wasn't appropriately filled out, or we didn't get all the information we
Right.
needed. And as far as the due diligence that we do to go through all the processes, I would say that, you know, we actually go outside of Blue Shield. Not only are we looking at our medical directors reading these studies, we actually find, you know, SMEs that are out there who come and meet with us, and we go through the
Subject
needs-
matter
subject matter
experts.
experts.
Oh, okay.
Right. Subject matter experts, who actually come for a meeting with us when we talk about some of these new novel drugs, to review them, to talk about them, and then we make those decisions.
And are you allowed to speak to, like, these drugs that we heard about from Dr. Stock, are they being approved, or are you
They
running
are
up
being
to-
approved.
Yeah.
That's one of the biggest drivers for the cost of healthcare going up right now. In diabetes care, it's the insulin. It's still insulin.
But is
but
it
it's the-
overall cost? I mean, because we have a reduction in hospitalizations.
I would say in pharmacy costs, the rising pharmacy costs are some of these new novel drugs, not specifically these, but I would say, when you look at the sulfonylureas and metformins, and then you compare these new drugs for the diabetes management, skyrocketing difference. And even the insulin is not just, when they get the pens, everyone's getting pens, those are 5x more than the syringes. And
But you are looking at all cost, not just the pharmacy cost, right? Because the pharmaceuticals are driving down event rates.
I don't think we've actually we haven't looked
I think
specifically.
it's so
It's-
hard for the
I think
health
I
plans
can't.
to look on that scale,
Yeah,
right? And that has
exactly.
been the biggest,
Yeah,
I think you implicitly understand that, but to measure it in numbers
yeah.
is challenging. You have to use natural data essentially
Yeah.
Yeah.
to,
We wouldn't
to
be able to
get
say that because we are
years
now
down the
giving
line.
Right.
this medicine, we have seen a decrease in our inpatient hospitalization.
Or you've seen a decreased payout over years, the lifespan of your members, which you will, but
We haven't
you
seen
have
it
to
yet.
pay now.
We actually have not seen it yet. The cost of healthcare continues to rise, especially with the new drugs that are coming out, not necessarily just the diabetic drugs, but
Yeah.
just some of these other drugs for these rare conditions, they're costing $1 million, you
But,
know?
yeah.
And they skew the whole cost of healthcare overall.
Although heart disease is going up and those costs may go up too, it's hard to know, but let's hear Dr. Kaplan who looks
Just
at
a
this.
comment, because I know we're over time, but, you know, PCSK9 inhibitors are a really interesting case study because that, you know, the indication you showed actually, you know, that they've gone back and they've gotten a wider indication now.
Yeah.
And so that, it opens up the market dramatically, so it's not just hypercholesterolemia, now it's statin resistant and statin intolerant, which is very vaguely defined. And although the cost has gone down from 14,000 per year to 58, actually makes a big difference if they're able to open up the market widely. And my colleague Kevin Schulman's a new faculty member here, but he's done these analyses and he tries to show that if the market expands by different percentage points, what effect it has on families, because it affects premiums. And so
It affects what?
premiums. So if you take a family, the average family of four in the U.S. has an annual income of about $60,000. And if they're able to increase the market for PCSK9 inhibitors into that sort of primary prevention market, it could be an increase in the average premium of $1,500 to $2,000 per year.
Well, it's very interesting what Dr. Kane said about not getting that LDL too low, and what you see with the PCSK9s is it's dropping it really, really low. So
Does anybody know what they're doing